All right, we're up. All right, good morning. I'm Jackie Wolf, and I was working on a team with Angeli DeSica and Nick Reed here with the social healthcare enterprise iCure. And iCure's mission, let's see if I can get this to work right. There we go. Was to actually bridge the gap between rural communities in West Bengal and critical clinical care that was actually located within like more urban settings. So we landed on the ground, and we were asked to help them enhance communication between doctors and community healthcare workers, which are the people actually working in these villages, handing out healthcare, giving advice, working with the people there, and actually streamlining and improving patient data collection. So right now, the women are going out into the villages, collecting information on these paper documents, and they really wanted to help streamline that efforts. So what we ended up doing is building a mobile app. And so they're able to go out into these communities with a tablet that then helps them record data. And as we were going through and developing this application, we came up with two general use cases. As of right now, the CHWs are working in these really remote communities, and they're tasked with checking patient vitals, giving out limited quantities of medication, and in recording health information. And right now, there's limited time and effort. They see 10 households every day. They have a number of about 1,000 people that they're in charge of. Generally, they have 3-minute visits per patient. If they're working with pregnant women, those visits take 2.5 hours. And generally afterwards, when they go and have to record the information, it takes about 2 hours after that. And so we're hoping through this application we could streamline that. And additionally, the community healthcare workers are only interacting with doctors when they're at clinical settings. And it's only really on behalf of their patients. So we were hoping that by actually creating real-time communication with doctors, they could create more of a collaborative environment where community healthcare workers could email doctors or contact doctors in real time if they had a question. And as we're doing all this, we're sitting in our little cubicles and working there for 2 weeks, and we're excited. We're going out to the fields. And as we're talking to the community healthcare workers out there, some of the questions that we asked are, what are your points of frustration? And I assumed they're gonna be like, oh, well, it takes me 2 hours to do data collection. It's really hot, I'm really tired. And when I asked one of the workers, what points of frustration do you have? She says, we don't have a bridge. So it turns out the community that she's working in during the monsoon season is completely cut off from the rest of the community by a riverbed. So the riverbed you're able to drive across during the dry season, but during the wet season, it's completely impassable. And she was working with the woman that she'd been watching for 8 months. She was 8 months pregnant, and one day she fell. And it was during the monsoon season, and so she couldn't get her to a clinic, and the baby died. And it was really heartbreaking to hear that, because you sat back and you're like, I'm working on this application to help with data collection. I'm working on this application to help connect them with doctors. This app can't build a bridge. It can't bridge that physical barrier. And so that really made us step back and think, okay, how else can this app empower community healthcare workers? Okay, maybe it can't get them to the clinic, but maybe by having that point of contact with the doctor, she can feel not as alone during those moments. Or maybe the community itself can keep track of how frequently these events are happening and actually use that to encourage the government to do more about this. And Nick's gonna talk to you a little bit more about what we did with the app.
Hi. There are too many things in my hand. Yep. So, we built a very simple application. We are calling this the KOL Health application. And basically what it does is it enables real-time data entry on a tablet. The tablet uses an offline first architecture, so it's really designed to work with no online connectivity and then sync back to a centralized server. There are many other applications that use this sort of model. Unlike many of them, this has a very patient-centered data model behind it, which really makes it so that we can enable case-specific messaging. So for any form that's entered and any case that's brought into the system, it enables medical professionals to communicate and collaborate within the context of the case. The app itself is mainly built out of Ionic, which is a PhoneGap plugin, and PouchDB, which is a offline syncing database. There are many other applications that do this sort of work. And we see our application really fitting into this group of work. We actually are re-implemented open data kits form methodologies in there using the Akento smart paper system, so that when someone uses our application, they can reuse different types of services that are offered by other companies that use open source platforms. I'd just like to point out that one of the very large groups the MOTEC suite, which is used by many other groups, was actually implemented by a University of Michigan grad student. So we're falling right in line with some really great work. And now Anjali will talk a little bit about what we found.
So in order to tailor this application to a very specific context, we needed to get to know the community and the community health workers better. So the minute we got to India, we started preparing to go into the field. It did take a little bit longer than we expected, but we were able to complete 3 different field visits in 3 different communities and interacted with a total of 6 health workers. 3 of them were ASHA workers, so they are employed by the government, and the other 3 were iCure's community health workers that they're hoping to train on this application so that they can implement it into their healthcare model. So the first community that we visited was Bhavanipur in Balichak, which is about 3 hours by train south of the main city of Kolkata. The second community was Bhainagar, also in Balichak. And then the last place was Jamdargur in Goda Piasal. So there were 3 very different communities, 3 very different groups of health workers and ASHA workers that we interacted with. But our testing process and the methods we used were all pretty much the same. We had about 3 hours in each community to interact with the health workers. And so we decided the best way to gather information was to set up semi-structured interviews with the different health workers and just get a better sense of what their workflow was like, what they did in the communities, what types of questions they asked, what forms they were actually filling out, how they collected information, and kind of what sort of buy-in they had with the community. We wanted to understand that relationship better so that we could see how this application would fit into that model. The second aspect of it was also testing the prototype of the app. And because we visited these 3 different communities at different stages of the process, we were at different levels of development with the application. So with the first field visit, we were able to see what patient registration looked like, how the health workers interacted with the application, and tried to register patients. We coupled that with having them fill out a maternal health survey adapted by iCure surveys and kind of tailored into the application for this context. We also had, in that same field visit, a little trial with a paper survey to see how quickly and how completely a health worker could fill out a paper survey versus on the application, so we could kind of troubleshoot some of the usability issues. Within the second community, we went a little bit further into the process. Beyond doing patient registration, we also added in cases. So a case form included collecting vitals, collecting symptoms. What sorts of vitals and symptoms were the health workers already collecting? What things would they like to see more of in the application? How hard was the application to use when actually filling out this information? That was what we really wanted to know. And because we were interacting with 2 ASHA workers in this setting, we got kind of a different perspective from what we observed with the community health workers from our first field test. We now understand that the health workers employed by iCure and the ASHA workers are 2 very different groups of health workers. The ASHA workers have a more standardized process because they're employed by the government, and they may have a different level of technology literacy or health literacy because of the standardized training that they generally receive. The community health workers employed by iCure have generally a 2-month training process and then are kind of put into these different communities, expected to connect with community members and get all the information that they need to collect for iCure, which is a very difficult process, as we soon found out. Finally, in the last community, we went a little bit further with the application and added in a messaging component to see how the health workers interacted with a feature that would allow them to refer patients to a doctor or send a message to an MD who is located in a clinic or a hospital far away from these rural villages. We got a lot of feedback on all of these different features of the application, but I think what was more important was kind of seeing what those interactions were actually like and get a sense of what the general work process was for the health workers and just what sorts of relationships they had with their communities. And I think that was definitely the most valuable learning process experience for us. So when we went into the communities, we had a very difficult time communicating with the health workers. None of us speak Bengali, Hindi, or any of the local dialects that were spoken in these various communities. So the iCare project manager volunteered himself as our translator. And because we had a very limited amount of time and a lot that we wanted to get done in these field visits, we thought, okay, that's okay. We expect him to be able to translate as much as he can back to us. It was a little bit challenging having him as our translator, largely because he is the boss of these health workers. And it was a lot more obvious when we were interacting with iCare community health workers that there was a very large power dynamic. And so we weren't sure how much of the information we were getting translated back to us was accurate or kind of biased by a perspective of what iCare thought the app was supposed to be versus what the health workers actually thought. And then also having someone very connected to the project, like the project manager, made it difficult to really understand some of the things we would have thought would be important to know, some of the stories that the health workers would kind of go off on, some of their experiences, some of their hardships. We didn't always get a lot of that, but for the stories that we were able to get translated back to us, I think that gave us a lot more context and a lot more information than just simply having, oh, they liked this part of the app, they didn't like this part of the app. Another thing that we learned was that the health workers are very, very invested in the work that they do in these communities. Whether it's keeping track of mothers and children or just random households in their communities, they are very invested in collecting as much information and as accurate information as possible. It's very difficult because currently they're all using paper forms in various capacities, as you can see here. This booklet actually is at least 300 pages long. It's a large manual given to ASHA workers by the government, and it's just a reference manual to work with mothers, newborns, and children, but it gives them all the information they need on what they should be doing in the field, what kind of advice they should be giving patients, how they should collect information. And there's a few pages with diagrams, for instance, on breastfeeding or taking temperature for a newborn. And of course, it's all written in Bengali script, which is something that was very eye-opening for us, especially because the application that we had built was only in English script, and we didn't have enough time to get it translated into Bengali or another local language. So seeing all of these different forms written in a local dialect, we realized was something that was very important for these communities and for these health workers. And so we see that as like a very important next step for iCare if they want to consider implementing this into these communities and ensure that the health workers do understand what information is being collected in the application, what the forms are saying. And then that also gets into some important literacy variations with the health workers, which we will go on to talk about soon.
So one of the really interesting parts that we found was kind of how the community health workers are understood and represented in the community. We heard a lot of stories about how the community would come to a health worker, an ASHA worker, and say, hey, there's a new woman in town, and they would actually direct the woman to the ASHA worker without the ASHA worker having to do anything. They would come and respect these people and really rely on them as a resource. But, you know, those relationships were not across the board. They weren't everywhere and predominant. And especially the ASHA workers themselves told us that when they're working with a patient or a mother, that there are many other stakeholders beyond just that mother that they need to work with to convince and to educate. Specifically, you know, the people who hold traditionally power in those communities, such as the mothers-in-law and, you know, the rest of the family who's part of the care team. Also, the literacy level in these communities varies greatly. We really found there are 3 types of literacy that are working against us in this project, from literacy levels of their knowledge of English, Hindi, or Bengali, and the fact that it can vary widely across each group, to actually their level of health literacy and how well they understand the health content that community health workers are speaking about, what they understand, what they can say. And lastly, the fact that digital literacy varies greatly. We've met some of the health workers who said, oh, we really want this to work just like our email, just like Hotmail. We met some who had never touched a tablet before and were absolutely scared that they would break it. So the absolute variance in terms of how they can use this technology and understand what it is and what it can do is a very big and difficult design consideration. Lastly, a phrase that kind of stuck with us is that in India, there are Indias within India. And this is not just a slide with food, even though we felt that we had to put one in there because, oh my God, it's delicious. Really, each group, each place, there's another place that's worse off, that's more remote, that's more ethnic, or something that another group will say about it. And so figuring out how to navigate that sort of relationships that these towns and these groups have with each other is really important and something to keep in mind that I think was really striking to us. But, oh wow, that text got really small. When did that happen? Anyway, the application that we made is really just the beginning. There's a lot of work that iCure has to do to actually move this forward, and no matter what we did in 6 weeks, there's no way we could start to move this forward. There's a lot of content that needs to be tailored in terms of translating it into Bengali, making sure that the forms are understandable and usable by the health workers, which is, you know, just one big step. They need to reevaluate what changes in their work process once they put a digital tablet into this environment, because that will absolutely quickly change it. They need to work on empowering the community so that they can start to understand what this tablet means and feel like they are being represented. And lastly, they need to figure out how to actually build the bridges, the real physical bridges that need to be built for the places where this technology is just going to be ineffective. Thanks so much. Here's us with the Taj Mahal. Does anyone have any questions?
Yeah, I'd like to start us off with one question, which is when the original project came to us, the group which offered it up to us was completely comfortable with all the work being done in English at the community health worker level. So that seems to suggest from your discussions that that assumption was very much mistaken. Okay, and over the last few months, you've also been looking at the CHW landscape across other projects as well. Can you talk a little bit about the gap between where technology is trying to be and how the people who build the technology see the value of the technology and what's happening on the ground?
Yeah, so some of the projects that we actually looked at were really interesting with the types of technology they were implementing. So ComCare was one of the applications that we looked at where they're actually using what we've been calling brick phones, where basically they're the Nokia phones with a 10-key type board. And they found that there was actually a lot of buy-in that the community members had using that piece of technology, even though they would be typing not in Bengali, but in their natural language rather than English, which is very difficult with the type of scripting that we're used to, being A, B, C, D. But because they were allowed to use them as their personal phones, they had a lot of investment in actually learning how to do that kind of scripting on their own. And so they would actually create their own kind of cheat sheet for like, this maps to this maps to that. And so it was hard to play off of that with a tablet because the tablet is not something that iCure is thinking is using as their personal property. But we did have people that said, you know, this is great because instead of the 5 different books that I have to carry around and wrap in cellophane and worry about carrying across rivers. I can just use this tablet instead, and that'll actually help me a lot because it means I won't have to be carrying this paper around. And also it means I don't have to worry about our documentation being lost, because they're carrying, some of the documentation they have is like 8 or 10 years old and is like fraying and is fading. And so they thought that there was actually value in this because it would be something that they saw as more permanent. But one of the things they are going to have to do moving forward is figuring out how to empower them more with this type of tablet usage. And so, as Nick was indicating, there was a lot of mental models they didn't have about how you use a tablet, whether that's scrolling or using like your finger to touch things or understanding what a button looks like. And so one of the documents that we left was really encouraging this type of secondary training. So it's not just training them how to use the app, but it's training them to feel comfortable with technology and understanding that they're not going to break anything when they try playing around with it, that this is a tool that they should feel like they have ownership over.
So I have 2 kind of different questions. The first, kind of following up on that, is something that we thought a lot about is the different ways that you actually can communicate. So like, have you thought anything beyond just script, like having maybe sound bites or anything like that? Or is that something that other places have tried? And then my second question was, when you talk to people about these documentations and the manuals and things like that, did you get any sense of like what parts of it were really important and like the most pertinent to what you were doing? And were there parts of this like 300-page manual that maybe could be dropped out or anything?
Yeah, so it's really interesting to hear from a couple of the health workers that, to address the first question, is that they, or I guess the second question, sorry, is that they really wanted to see the application with all the forms that they had currently been using. So we did start off with patient registration, cases including vitals and symptoms, and then a basic maternal health survey, just to give them a feel of what it could potentially look like and give us kind of a foundation to build off of. And we certainly didn't put a lot of content into it. But yeah, one of the suggestions we did have from a health worker was that, oh, you know, this would be great if I could have these other forms in this book that I have input into this application, because then all of the information will be secure, all of it will be in one place, and I don't have to carry like these 10 other books with me. Because in addition to that, they also have to carry their medical equipment to take vital measures, and it's just a lot for them to worry about. And I think for her in particular, this was seen as a very simple solution to that, and would be a better way for her to collect the information.
Sure. So we did think a lot about just the literacy and accessibility issue, like especially other modes of communication. The fact that they're holding what is actually a cell phone. Cell phone and telephony seems to be the mode of communication they're most familiar with. And especially for just the messaging feature, that seems to be the path of least resistance. We've thought about implementing it. It's kind of on our next, 3 weeks timeline, which, is in their hands right now. But the technology does support it, and we see no reason why not. Mainly because those sorts of messages, they're not supposed to be documented in a medical record, or the value isn't there. It's more for communication now versus readability later.